Hi, hope you're all well. I'm Viv and I'm the face behind Skinpharma Aesthetics in Stockton-on-Tees. Tonight, myself and Dr. Sunny are continuing our journey in the use of ultrasound in our aesthetics work. Hi Steve Harris from London, and hi Barbara, who's our guest this evening. I will add Sunny first, Barbara, and I will add you soon afterwards. I'll just send Sunny an invite. It shouldn't be too long. But yes, we're continuing our journey in the use of ultrasound in our aesthetics work, and we're very proud and happy to be joined by a specialist from Argentina this evening. I'll just send Sunny an invite. There we go. It shouldn't be too long, hopefully. Hi, Sunny. Barbara Barrera is a cosmetic doctor in Argentina, and she will hopefully be joining us soon. I'll just send an invite to Sunny again. There we go. That's Sunny. Barbara is a practitioner who I know because of a group of practitioners called CMAC who are based in the UK. Hi, Sunny.
Hi, Viv. How are you?
Fine, doing well, thanks. Have you just got back from London, did you say?
Yeah. I was on a GP training day, and because there was a rail strike, I literally have just walked in through the door. So.
Oh dear. Are you okay to carry on? Are you?
Yeah. You know when you send, you know when you always say I'm sending an invite.
Yeah.
There's never an invite. An invite never comes. I think you're just lying. I think you're just teasing us.
I must be inviting someone else who never turns up.
No, basically, because when we go on, you click send a request to join the live, and then literally when I'm pressing it, you say, "Oh, and I'll just send it." But no invite ever comes in, so I don't know what it is.
Hi, Barbara.
Barbara, hi.
Hi. How are you?
Yeah, good.
Patricia Barrera. Patricia. It's nice to see you. Yeah, nice. Sorry I messed your name up.
Thank you very much for the invitation to do the live.
Oh, it's a pleasure to have you. Sunny will. What I'll do, I'll let Sunny speak to you first, Patricia, and he'll have a little chat about your background, about how you've got into the work, and then we'll go through a case that you've been involved with recently. But I'll let Sunny start if that's all right.
Perfect.
Great.
Hi, Patricia. Sorry, you caught us, Viv and I, arguing like a married couple just before we start the live, so apologies. So welcome to our live, and it's an honour and a pleasure to have esteemed colleagues on to talk to us about their practice, about their past, and their future. So on that note, for those of and I can see you're very popular because already we've got loads of people turning up. So that's brilliant. So tell us a little bit about yourself, your past, kind of your how you got into medicine, and then also how you got into cosmetic medicine, and then I'll lead you with some questions from there. So please tell us about yourself.
Well, I actually used to live in the States, in the United States. I graduated from Concord High School, New Hampshire, in my high school, and then I moved back to Argentina for my med school. I finished med school and I went back to the States to do the USMLE, which is to be able to work there. But when I was going to take my second test, I decided to come back to Argentina. The love of my life lives here. I am married to him. We have been together for 21 years. So I decided to come back and start my career here. And I started, by that time, when I started, cosmetic physicians weren't here in my state seen very good. It was 2008 or so, and I started doing surgery. I started in a public hospital in my residency, And then I realized it wasn't what I loved. I was kind of afraid to follow what I liked by then, because it wasn't like well seen. And then I said, this is what I love. I'm going to pursue what I liked. And I started studying for that. And that's when I decided I was going to be a cosmetic doctor. And actually, I started in 2009, and I have been doing that since. And I love my work, and I love the people I have met, and I love my patients. And it's not one day that I have to work because I loved it. So it's what I didn't regret what I did.
No, exactly. Enjoy what you do in your love life. Yes.
Now we're fighting for this to be recognized as a specialty here in Argentina, because it has to be recognized. It's not like you cannot go to a doctor like some treatments, we have a lot of education to do, because it's not like going and buying a sandwich. You know what I mean? So it's not like we have to teach a lot of the population too. So we are fighting for this to be specialty and be recognized as such here in Argentina.
When you were doing your USMLEs, did you already have a good idea of what you wanted to do in medicine, or were you just wanting to get that sort of your kind of level where you were at, obviously to work in America?
No, I thought I liked plastic surgery. I thought that was my inclination, and when I returned, that's what I was going to go for. I did general surgery first. But then I realized that it wasn't exactly what I liked. But I was inclined to do something like plastic surgery until this field started to grow. And then I said, much more this specialty.
Did you take the plunge yourself into cosmetic medicine, or did you kind of meet someone who was doing it at the same time? Collaborate with someone, or did you just kind of go by yourself and like, this is what I'm going to do?
I always had an inclination for aesthetics, and I started seeing that I liked it. And by then, when I started doing surgery, I asked to be like, here we have two kinds of specialty, and it's like you have more free time and you don't get pay. It's like different than residency. And I started traveling to Buenos Aires, because I am far from Buenos Aires, to study. And that's when I realized that was what I liked it more than surgery. But I always was inclined. I always knew I liked aesthetics.
Good. No, amazing. And a lot of us have gone that journey as well, afraid to sort of start it, but then obviously having a love for it. What procedures did you start off doing first? Did you go straight in with dermal fillers, or did you do botulinum toxin or wrinkle smoothing injections first? Where did you start with?
Actually, well, I have a story with fillers, because when I started doing Botox, mesotherapy, energy devices, plasma-rich factors, a little bit of everything. And in 2011, I did to do a kind of like relearning to do fillers in Massachusetts. They didn't even talk about adverse. By then, we had to first convince the patient to do a filler. Like, we have to, here, at least in Argentina, then you usually learn how to feel nasolabial folds. We sometimes with cheek fillers. We had another approach to what was fillers than what we know now. And there was something that I didn't like. There was something that didn't make sense for me. I did fillers, but something was not right. I had that feeling. And I went in 2016 to Monaco, AMWC, the Congress,
Yeah.
and 80% of the lectures were about complications. And that's when I said, I knew something was wrong. So I think now, with all the information we have, doctors who wants to do aesthetics first needs to know if they want to do just fillers and Botox, and that's not aesthetics medicine. You know what I mean? And then
Yes. Yeah.
if you want fillers, you need to know first the complication. That's what I think. You need to learn how the complications happen and what to do before putting a needle on a face. And that's what I believe, and that's how I manage my career. So I stopped doing fillers for a while, and I made myself sure when I go to bed at night, I have to know that I did everything for the safety of the patient. So I know where did I inject and why, what product, even if it's Botox, whatever you do, you need to know why are you doing that? What is the indication for the patient, if that's the best treatment the patient needs, and how to do it and where to do it. So I stopped doing fillers for a couple of years, and now, because we know more, and I learned first the complication, then I start doing fillers again.
Before I hand over to Viv, I have a question though. You must have some patients, and obviously I've looked at your Instagram feed, you're very passionate about aesthetics. So you must have been doing some fillers, you must have seen some patients, and then obviously done a good job for them, I'm sure. But then the 2 years where you weren't doing it, did the patients come back to you? Were people still asking you to do fillers? What did you do during that 2 years then?
Actually, well, I did all the other stuff aesthetics medicine does. I mean, it's not. That's why I'm saying maybe some people wants to do just fillers and Botox, but if you want to do aesthetics, aging happens in all the layers. It's not just fillers. Yes. The thing is that filler gets you a quick response when you treat just the skin, and when you treat just, you know, like you stimulate the collagen, for example, and you do even if you do Sculptra, Radies, or whatever you choose to do, it's a long-term result. When you do Botox and you do fillers, it's a quick result. So people love it. But what I try to explain is that if you don't take care of the whole thing and you just feel the face, I mean, fillers don't lift, and you can return volume, but you just need a whole approach to age better. We are not going to stop aging. We just need to age better. So that's what I did. And then it was like the missing puzzle in my practice that I need to finish doing. But I needed to do it sure that if something happened, I knew what to know, or I have an idea that a couple of years ago nobody talked about it. So now it's easier for people who want to study because they can learn before. It's like going into a car, or like everyone likes to go to a car, but if your tire gets down, you need to know how to fix it, or you will need someone else to do it. So it's better for you to do it. So kind of like.
Great insight, and Viv and I are both very much advocates of aesthetic medicine and that holistic approach. Viv, go on. I've monopolised Patricia's time for a little bit, so go for it.
Sunny always has the first word in, Patricia, but I tend to get the last word in, luckily. So it's nice to see you anyway. We actually met up via the internet because of a particular problem that you had a few weeks ago. You're a member of CMAC, as myself and Sunny are as well. We're all members of a body based in the UK that work with practitioners all around the world, including yourself, to look at complications in medical aesthetics. And with myself and Sunny, we were looking at the forum, the CMAT forum on Facebook, and you posted a few weeks ago about a problem involving lip filler, and it was strange because ultimately we found out that we knew each other via another practitioner, Carolina Marilewis, who's based in Argentina, and she's a radiologist, and she specializes in aesthetic problems and uses ultrasound to assess and treat problems as well. So we actually found each other via someone else, and via CMAC in particular. The issue involving lip filler was what the problem was for you and for your patient. Can you tell us a little bit about the background, what came about and what happened? I've got some photos and videos that I'll show as you talked, but can you just explain to us what happened, what the problem was involving the patient and with her lip filler? Can you just give us a little bit of background about that?
Yes, I actually, Carolina has helped me a lot. She knows a lot. She's a radiologist and she has a lot of knowledge. And I got my ultrasound. I had been waiting for it a long time. And it was a Friday. I did the introduction course with her. And on Saturday, I did this filler, and this happened. The first day I was using my ultrasound. I'm like, I saw this patient, a very beautiful girl, 28 years old, so she didn't need anything else. And she wanted a little bit of lip. So I noticed an hypopigmentation in both upper lips, where the tubercles are, and down in the middle of the lower lip. And I talked to her about it before doing the filler. I told her I noticed this and that this was in both lips. And she said, yes, I know. All my life, I had been thinking like this happens. And in the couple of years ago, I have been thinking about tattooing my lips with color because they have this problem. And so I noticed this, I do the filler, and afterwards, after I finish, I do the recapillary refill time.
Yeah.
And it didn't make like exactly like, it wasn't more than 3 seconds, but it wasn't like normal.
Yeah. I'm just going to try and see if I can get it playing. I'll be 1 second. Just want to play. I'll be 1 second.
So on that note, Patricia, what was it that prompted you? Because if you look at the color of the lips there, just in that picture, they actually look fine. What was it that did you routinely test the CRT, or did you just see something that wasn't? What was it that sparked your kind of interest in the maybe that?
I usually do the ultrasound just to see where the arteries are. Yes. And now I do it because I have been using it since a short time. Sure. But what I do the ultrasound, I check where the arteries are, and then I decide how I'm going to approach the lip filler. But I mean the technique. But with this patient, I did the ultrasound, everything was okay, and I didn't videotape the recapillary refill time before doing the filler, and that was my mistake, because after the filler was done, when I did recapillary refill time, it was delayed. It wasn't like more than 3 seconds, but I was in doubt. So I did the ultrasound, I saw flow, but I am new at this. I am not an expert. So I asked her to stay for 1 hour. Actually, that was like after 1 hour. And I asked her to send me a picture the next day. It was a Sunday. It was, yeah.
This was an hour after the treatment was carried out, I think. Yeah.
It was kind of delayed. And because I had the ultrasound, I checked, she had flow, and I didn't see any more extended signs of an alteration. So now I said, I'm going to wait. I asked her the other day to send me a picture because it was Mother's Day here, you know, and it was okay. I asked her to go on Monday. I actually asked Carolina to help me out because I am new in ultrasound. I didn't want to mistake a diagnosis, and then my patient will be like in trouble because of my negligence. So I asked Carolina to help, and then I posted in CIMAC, which I think it's a very good group to join. And I actually talked to a lot of my colleagues about it. And Dr. Weiner, which I really admire, and Stella, that are two great professionals in ultrasound too, they helped me out with the case. And she didn't show any other sign. At the 4th day after the filler, I did another ultrasound with Carolina online live, and it showed flow. So I didn't dissolve it. And I saw her again, and she's happy about it. But it makes me realize that when you have an hypopigmentation, that I believe she had 4 this spot, but they weren't like they were like very, very small, but it did a lot of hypopigmentation. That was one of the things that I said, she doesn't have any other sign, and it's bilateral, and it's like exactly the same. Am I going to be that good to obstruct both arteries? I'm like, I hope not. So that's when I start, you know, with CIMAC advice, and, you know, Dr. Weiner was very helpful, and Stella. That I decided to not dissolve, and nothing happened. But if I always said to other professionals, if you doubt about it, you have to take it out. But I didn't, because I have like this backup. I asked for help, and I didn't want it to dissolve because she was happy. But if I am in doubt, I'm sorry, I'll take it out.
It was just the fact that you had the ultrasound and you were very, very new to using it. So it must have been very difficult for you to try and figure out what was happening, even with the device at hand. But as I was saying to you, there's always support available from other people around the world if you need it. And I think Carolina was actually in touch with me the day I saw your post. She was in touch and she said, Viv, somebody I know has got a problem and they're using a Clarius ultrasound scanner. Can you help connect us together? So she asked me for a little bit of advice to help you speak to her with a live connection so she could see what you were scanning. And I think it helped you both in some way to try and figure out the actual state of the patient's lips. Luckily for you, there was no problems, but if you hadn't have had the device and you couldn't tell whether there was a problem, do you think you would have dissolved? Do you think that's what you would have done?
Yeah, if I doubt, I rather dissolve it, because then the patients, but I don't like, sometimes you don't need to dissolve it, but you need a lot of casuistic, and you need a lot of experience to say, I'm not going to dissolve it. And then, you know, but sometimes I think if you don't have like a vision alteration, that's an emergency, you can take a little bit of time, lay down and really study the patient and see what's going on. That's what I'm trying to incorporate, right? Because maybe you start to be like with a lot of you know, I don't know the word right now, but do you know when you get scared?
Yeah.
And then maybe you need to rush, and you have a couple of minutes to lay down, think, and do things the right way, unless you have an emergency. It's urgent, but it's not. You cannot stay like 3 days. You know what I mean? Everyone knows the hours are not exactly the same because people are different, and there's some cases that takes more time than less time, but there's signs that we can look, and it tells you that something is wrong and you need to dissolve it. But I think if you have an adverse event, as soon as you dissolve it, the better.
Yeah, yeah. It's just the scans. I was going to just show the scans that you carried out, Patricia. So this was the first one. I think this was with quite quickly after, well, 3 days afterwards, you carried out some scanning, and the blood flow didn't look like there was a problem based on what you saw and what Carolina saw. There wasn't actually an issue. Same again with other areas. That was the upper lip, midline, complete flow across the superior labial artery, and that's something that you wouldn't be able to tell without the ultrasound. You wouldn't be able to tell if there was an issue with the blood flow. Again, you carried out more work on 72 hours, upper lip, left. You checked the left side, you checked the right side. Flow wasn't particularly a problem. You were just worried about the symptoms, looking at the lips from the capillary refill time. Again, you looked lower lip, right side. This was all done 3 days after the treatment was carried out. You did lower lip, left of midline, very close to the surface, I think, where that scan was carried out. But there was no particular problems based on the appearance of the blood flow. You looked at
just for Viv, just for people who are watching and maybe obviously maybe don't understand it. So just if you hold it up and just describe it. So obviously in some places the artery does look very superficial. Was that the case, Patricia, that the artery was very superficial? What technique did you use then? What technique did you use? Did you thread filler over the top, or were you tenting?
I did very small filler, very, very few. I put in total 0.02. So I did very few, just to give her a little bit of form. I didn't do like volume in the lip, and I would maybe, if I would just needed volume, I would have used cannula. I did with needle, very superficial, and very, very, very few. Like it was like retrolineal and I didn't do bolus. I didn't do it intramuscular because not with the. I like and I hope I like the technique from Dr. Harris. So sometimes I will train with him. I admire his work, so I like it very much. I don't like. So
I actually spoke to him this evening, Patricia, and I said about this topic, tonight's topic involving lip filler and yourself. I told him how much you enjoy his technique to work on the tubercules, the lip areas. And he's going to be at CMAC next weekend, so you may well be able to have a good chat with him about the whole area of lip filler treatments. I think you'll enjoy that.
Yeah, I like his technique, and I usually use that technique, but I put a very few amount of filler. I used a small amount. I didn't do bolus, but still, when I did the capillary refill time, it wasn't sure. So that makes me think not just the hypopigmentation, but also the people who do tattoos in the lips. Yeah. How do you assess the recapillary? I mean, you need an ultrasound or wait until you have another signs, and it might be kind of late. So that's interesting. It made me think about this situation.
Yeah, it was just, this was the actual, at 5 days, I think it was 120 hours afterwards, you carried out. It's just the appearance. Again, you weren't completely happy about how it looked, I think. That was one of the problems, wasn't it?
No, I wasn't happy because it was still pale. But it was the problem she has, and she had it all her life. Because it's good to talk about it before doing things. I usually have some patients that have like more whitish around the area, I also address that. Or if patient has their skin is very white and they get red, when they get like red, they get like some kind of spot, white spot, and you have to address that before doing an injection. And you have to talk about the same thing when you do toxin and the patient has asymmetry that they have since all their life, and they started to see now because they have started to do treatment. And they said, I never noticed this. And I'm like, well, you have this all your life. So that's interesting. All the asymmetries and, well, with the lips, asymmetries are very difficult. But I always address the things before doing anything on the patient, because then it becomes a problem. And I always take pictures and sometimes record things. And I think it's important for the physician to address these things, the hypopigmentation or these things like if you have a tattoo lip, how do you assess the recapillary fill time? Or if you have an asymmetry, because people don't notice until they become older. Sometimes, and you said, well, you have this eyebrow different than this one, and they say, oh, I never noticed, and then they think you made it. So it's important to address before any treatment.
No, that's
because of your case. Sorry, sir. Because of this case, you know, I've changed my practice a little bit. So what I now do, I check capillary refill in patients who I do lip treatments for. I do a lot of lips in particular, and because of the different colours of skin that you see, it can be a problem identifying an occlusion or a problem following lip filler treatment. So I do a little bit of CRT work, you know, just checking the capillary refill before I start doing injections, just to see what it's like before there's a problem, if a problem were to occur. So that's because of you. I've changed the way I work because of the problem that you had, Patricia. So I've got to thank you for that.
Oh, good. I'm glad we learn every day. I always said we are always the students. Even the experience gives you a lot, but we always learn. So I love, that's why I love the interchange between professionals, because something that we might find out during our practice, it might help others. So I always like that. So that's good. What I do now is I record the capillary refill time, and then I if nothing happened, then that's okay. But the first time it happens, obviously I didn't have it. So it has to help me to improve my practice. We always have to improve with small things. So that's why I like always CMAC, because sometimes you have a case and you don't know about it and you learn. And what I explain about complications is I have heard in Congress and in lectures or masterclass that being an expert in complications, it's not like the best. And I think because some people think that if you know about complications, it's because your patients get complicated. And that's not true. You know what I mean? I believe that if you know a lot about complications, you can also know what you are doing wrong. Because now you see with ultrasound that some of the injections that you thought were in a place are not. So you learn also, for example, there's like another ones that I really, they are my, I admire are Leonil and Tom Decades. And they just, Leonil talked about supraperiosteal injection. So, so you learn a lot. And it's not that you did that wrong before, but we didn't know. So we have to adapt and learn and keep changing the technique to have the best outcome for the patient.
Amazing.
Patricia, you have...
was there any questions?
Sorry, Viv,
questions, Sunny?
Yeah, I was going to ask. It's just a good insight. I think a lot of people don't actually record the capillary refill before they do a procedure, and I think that's it's a great lesson that you've shared with us there. Sorry, Viv, you're going to wrap up?
No, I was just wondering if there was any questions at all, Sunny, from anyone.
Questions?
That
No,
might
we've
have
got.
typed in a question.
So no, we did. Sorry, Viv, say that again.
Just checking the question. Oh, there's one from Dr. Parder there. Just a question from a. How do you assess?
No, we had lots of mentions and hellos. Dr. Martina Lavery is watching. Carolina Mary Lewis is watching as well. She said hello. And I think the last question, yes, from Dr. Prada. How do you assess paleness or CRT with the lips having permanent? So you must see that, Patricia, in your work, that if they've had permanent makeup already, does that affect how you see the capillary refill time?
I have here in where I lived, the same as like for my city, it's a small city. We are not like Buenos Aires. I had been seeing in Buenos Aires, for example, a lot of silicones. We permanent fillers. We don't see as much in the other parts of like in.
Oh, I think
much as in
if you have tattoo, if you have the lips tattooed, yeah.
Tattoo here, it's starting to be popular.
Okay.
But now if I would have a person with a tattoo on the lip, it's kind of, I would do the ultrasound first.
Okay.
I would also do the capillary refill time, but I don't know if I would do a filler on a filler on a lip if I would not have the ultrasound.
Yeah, because it'd be
with a tattoo on the.
It'd be very difficult to identify the changing color, wouldn't it? It'd be very difficult if the color.
I think you will have signs, but it will have to be, maybe you will have a delay. Sign.
Yeah.
I don't know. It has to be very big to have it. I don't know. You have to be more careful. That's it.
Yeah.
Or more attention and record and
record.
Patient, educate the patient. Educate the patient what to look for, because a lot of times if you do a Botox, like a toxin, and the patient has an hematoma or whatever, it's okay. Like patients don't call you and they say, oh, I didn't call you. And I'm like, if I'm doing a filler, I educate the patient. I show pictures of what to look for, because maybe it's okay and the capillary fill is fine. And then when the filler starts to grabbing water, then it compresses the artery and then you can have a delayed complication.
Yes.
So you need to educate the patient and tell them, if you see like a bruise, and I listened to this to Wayner, he said this, and I learned a lot from this. If you see a bruise anywhere in the face that is not where injected, you call me. And because that's an occlusion, and I show pictures of what to look also to the patient, because sometimes the patient says, this is going to happen, I'll wait until tomorrow because I'm busy. No, you need to call me. And then I decide if that is a bruise or an occlusion. And then it's on me, the decision is on me. So I think I will do and teach the patient what to look for if you don't have ultrasound, and pay more attention to people who have tattoo on the lip. Because for me, I think it can, like this, like hypopigmentation. And if you have a tattoo in here, and you can't assess the thing is that this is new. They use a lot of different colors. So it's also how much colors did they put in and what kind of color. You have tattoos that are very good and tattoos that are not that good. So I think it's a multifactorial factors that involve.
Factual approach, yeah, definitely.
Yeah.
Viv?
Amazing. It's been great talking to you, Patricia. It's been really nice speaking to you. And the fact is, we've not met, but I think you will be at CMAC next week. Is that right?
I'm going to try to book my flight now after we hang out.
Oh, wow.
I have been working, and I really would like to go. So now I have a friend who I said, I want to go. And she said, let's go. And I'm like,
brilliant.
Oh my God.
Brilliant. We will be there. We will be there.
So,
lot of the practitioners myself and Sunny have spoken to over the last few months, the specialists from all over the world, they will hopefully be there. So it'll be nice to actually see everyone face to face for a change. It'll be nice to be able to speak to you properly. So we're looking forward to that. Really nice, enjoyable chat with you, Patricia, and I hope you enjoyed. I hope you enjoyed talking about the issue involving your patient.
Yes, I think the most important thing about this is that for me, ultrasound, it's not you need to learn. It's not easy. I mean, the first time you put an ultrasound in someone and you see all gray. That's the truth.
Yeah.
And I love I told Viv, I love what you do with the colors, and I would love to put the ultrasound and see all the layers with the color already.
Yes.
That doesn't happen yet. So it has been very helpful for me. We have to make conscious on physicians too, because if you are injecting since 15 or 16 years ago and you never had a complication, it's very difficult to convince someone to take a lot of time to learn ultrasound when nothing happened to you. So I understand that position, but I also understand that always is safety first, and everything we do, I think it's very useful. It's useful, and I heard Tom Decade said it's the how do you say I don't remember the ultrasound. It's the a stethoscope.
Yeah.
For the cosmetics, I love that phrase. I'm like, it's you can actually see where you're going and what's going on. So I am pro ultrasound. I think physicians should think and reconsider it. It's a long road, but it's worth it. I think it's change how we practice, what we do, and the decisions we take.
Yeah, I couldn't agree with you anymore, Patricia. I think we both agree, don't we, Sunny, about that?
Definitely.
Thanks very much, Patricia. Really, just to look at next week, next Thursday, we'll be talking to one of Leonie Schelke's PhD students next week, Dr. Olga Liplavik, I think she's called, and she's studying dermal filler breakdown, how dermal fillers change over time. So we'll be doing a live with her next Thursday at 8:30, and Sunny and I will be over in London after that for the weekend. Next weekend we'll be at the CMAC conference. We'll hopefully meet up with you there as well, Patricia, as well as all the other practitioners we've spoken to. So we'll enjoy, hopefully, being able to see you face to face after today.
Me too. Yeah, I have a long flight though.
Yes, yeah. I'm sure you'll enjoy it once you're there. I'm sure it'll be fine.
So I hope I'm going to get it now. So
right.
Good. Go and book it. Go and book it now. Go and book it now.
I would love to meet all the people that I admire because of your work, and you too. You both have done a great job doing these lives that I love. You have done a great work making conscious, and sometimes what I see, and I was talking to a colleague here in Argentina that does a lot of complication too the other day, and I said fillers courses, and he said filler courses fill in 1 week, and complications courses doesn't, and it fills in 1 month, and it should be the other way, We have to, and so I'm very, very thanks to your work, both of you, that you take time to make awareness of what is best, and always on the safety and thinking about the patient.
Thank you very much for your kind words.
Thank you.
It's very nice. So we'll say thanks. We will say goodbye to you for now, but we will hopefully meet up with you next Saturday, the end of next week, and good flight. Have a good, safe trip to London, and hopefully back again as well. So thank you very much for joining us this evening, and we'll catch up with you next weekend, hopefully.
Thank you. Yes, hope.
Hope.
Thanks, Viv. Thanks, Patricia. Hopefully.
Okie
Fingers
dokie.
crossed.
Thank you.
Fingers crossed.
Bye.
See you again soon. Bye.
Thank you so much. Thanks. Bye bye.